Nima, thank you so much for joining me. I just wanted to start out by giving the people some context about who you are, what you do, and why you choose to do it. You're a lower limb specialist, trauma surgeon, professor. You're going to do a better job than I will, but who are you? What do you do? And why do you specialize in lower limb trauma?
My name is Nima Hidari. I'm a foot and ankle and lower limb reconstruction surgeon. I have a particular interest in the traumatized foot and the lower limb. My orthopedic training has been at the Royal London Hospital. Royal London Hospital has been a major trauma center for many years because of the air ambulance. There has always been a helipad on
Mm,
the roof of the hospital, and the air ambulance has brought multiply injured patients, what we describe as polytraumatized in medical nomenclature. So the multidisciplinary team, the all of the subspecialties and the complex care that these patients require has been ongoing, developing, growing at the Royal London for many, many years. I trained there. I had my orthopedic and trauma training there. And the first week of my training actually coincided with the 7/7 bombings.
wow.
Being in East London, we received a huge number of casualties. We had lots of walking wounded, but also we had, I think, 15 or 16 of the patients that were uh, in the tunnel when the bombs exploded. So we were then looking after these poor souls
Mm,
for a prolonged period of time. And the thing that struck me was the amount of effort and infrastructure genuinely required to look after these multiply injured and patients with very complex injuries. The subsequent 4 weeks of their function of the hospital, particularly in the orthopedic department,
mm,
and to some extent the plastic surgery department, was taken by looking after these patients. So I had an early introduction in what it is to look after these poor souls. They present very interesting problems. They present evolving problems. It requires you to think. It
mm,
requires you to be very focused on identifying their aspects of their physiology, anatomy, and psychology
mm.
that actually need to be treated. I then returned to the Royal London as a consultant, and having trained in essentially a lot of lower limb reconstruction, foot and ankle surgery,
Mhm.
I had the interest to look after the traumatized foot. And before I started at the Royal London, there was no formal interest. None of the colleagues there had a particular interest in looking after injured feet. And that's provided
Mm,
me with ample amount of work, and I developed the foot trauma unit there. And with the interest that I had in the lower limb, I also started looking after patients with bone infections. And maybe a little bit later, I can talk about why that is an important thing and the consequences of individuals having complex injuries and why you need to be able to look after patients who have bone infections, deformities,
mm.
and failure of metalwork as part of the injury and the sequelae of the injuries that they have.
Okay. So setting up a whole, foot and ankle trauma unit, that is incredible and invaluable experience, probably for the hospital itself and for you. What were some of the benefits and improvements that you saw from setting up that, and what did it teach you?
The most interesting thing for me was the need for multidisciplinary work. When you look at these patients who have foot injuries, invariably they have multiple other areas, organs, and anatomical structures that are injured.
Mm,
They have tibial fractures, so the tibia is the shin bone. When we look at open fractures, when the fracture is severe enough for the bone to break through the skin, we see that tibial fractures are actually the most common open injury, and they require an enormous amount of work to look after them. They require multiple disciplines. They need vascular surgeons, they need orthopedic surgeons, and plastic surgeons to reconstruct the soft tissues. The interesting thing about foot injuries is that they really do have a profound impact in the overall outcome of trauma. One of the papers which I find very interesting was written by the group in Toronto, who are very well known in uh, describing some of the ways that we look after traumatized limbs.
Mm.
They looked at two groups of individuals. They were all young men and they had polytrauma, so they had multiple fractures. They looked to um, control for foot injuries. So they were both the same, equal number of injuries and so on. But one group had foot injuries. What they looked at is that 2 years down the line, they looked at the quality of life of these individuals. They asked questions about how they feel. Are they able to look after themselves by doing their normal daily activities? How far can they walk? Can they participate in sports?
Mm.
And what they found is that the group who had had the foot injuries on all measures had lower quality of life. So, foot trauma does have a profound impact on the overall outcome or for these traumatized individuals. So, what has happened since that paper has come out? We have become much better at looking after foot injuries. We now realize that reconstructing the anatomy in these individuals is really important. Creating or recreating the shape of the foot is really important. The thing that still stands out, once you have a complex injury to your foot, unfortunately, the foot is never the same again.
Mm.
One of the other interesting parts is that if you look at all of the individuals who have arthritis in their foot and ankle, and then you wind back to see what event has brought this about, trauma occurs in more than sort of 75, 80% of these individuals. So, trauma of the ankle and trauma of the foot almost predicts the fact that you will end up having arthritis. And arthritis means having stiffness, pain, and possibly deformity in that limb. The other side of it is that the soft tissues around the foot are incredibly specialist. And as a result of trauma, if you end up losing some of these soft tissues or get complex scarring, that also has long term consequences. The soft tissues of the heel pad is incredibly specialist. And in fact, reconstructing it, we haven't really found a good way to do it.
Mm.
So if we have an individual who has uh, terrible problems with this soft tissue, sometimes they end up with a below-knee amputation. And I use amputation in the term of it's a reconstructive option.